Well, thanks for your attendance here. My name is Richard Miltenberger, and this is our legislative panel, as you can see. Your conference organizers went above and beyond this year. We arranged to have a special session of the legislature that would end last night, just in time for this. And so what we've done, you'll notice that this section has certain topics that we've outlined. I think one is transparency. There's a couple of others, but we've informed our legislative panelists that given the fact the session has just ended, if they have something that's near and dear to them that they want to talk about, it doesn't have to fit within the pigeonhole of what's on the conference program. We're going to start with having each of them speak for 5 to 8 minutes, something like that, several minutes, and what's kind of floating their boat right now, getting them excited coming out of the session, or maybe just coming up with the interim committees, be it the transparency bill or be it any other issue. And then we'll have time for interaction between themselves as well as from the audience here. So we have with us, and I'll just do the introductions for all four right now, and they're in your program. But we have, let's see if I've got them in the right order here. Yeah, we do. We have, almost the right order. We have Senator Ed Buttry from Great Falls to my immediate right. Sitting next to him, we have Senator Mary Cafaro from our own Helena. We have, next to Mary, we have Representative Kathy Kelker from Billings, and then Representative Dennis Lenz from Billings, who will each have their perspective on HealthCare and what it is that's most important for us as a state to begin to focus on in light of changes with Medicaid expansion, possible changes with the Affordable Care Act, and the various bills being considered by the legislature. And we'll start and just go left to right. If Senator Buttry, you could address the audience with your remarks.
Thank you. Hopefully you can hear me. I can't pull this up. I'll lean over. I'm Senator Ed Buttry. I represent Senate District 11 out of Great Falls, and I'm happy to be here. We just finally got out of our session a couple hours ago, and we've had a couple long nights. We've had committee meetings till the past few nights till about 2 a.m. So if we're a little goofy, that would probably explain a lot of it. I do want to talk a little bit about the special session and put things in perspective as to how well we work together up here in the state of Montana. We were called into special session, and all this started about 5 months ago when we saw our revenue steadily declining. We saw that our ending fund balance, our bank account balance, was going to be insufficient, and in statute we call that 17-7-140, and when that happens, automatic cuts are kicked in so that you can hopefully retain the ending fund balance that you're required to hold for a balanced budget in Montana. Well, we hit that level, and we had a little bit of disagreement as to who should make the cuts, as to what ways we were going to explore to raise revenue, and where we could find money in government, because ultimately nobody, whether you're Republican or Democrat or Independent, believed that we should cut the services to the most needy. And there was some politics that went on in there, but we were all there with the goal of we have to protect the most needy to our greatest extent, knowing that we're out of money, that we're bankrupt. So we came together with a $227 million hole. Some of that was due to the fire season, which we just had. We have to pay off that debt. We have to restock the fire fund so that we can handle a fire season next year. And then we had to find a way to increase revenue or put money in the bank so that we were back at our balanced budget and we met the requirements of our statute and Constitution. And we did it. And we did it in 2.5 days. And my good friend Bruce Spencer just gave me an interesting tidbit. The state of Oklahoma has a budget shortfall. I believe he said $215 million. $215 million. State of Montana, $227 million. The state of Oklahoma legislature has been in for 6 weeks and still have no solution in sight. We came in with a higher budget deficit and did it in 2.5 days. And I think that's pretty exciting. So I get a little frustrated when we get the hate mail we're getting now, and we get some of the things that may be said or come out in the press. It's pretty incredible what we did without raising taxes. And as Mary, I know, isn't completely happy, but I hope we did some good things to be able to give some money back into those areas where the people need it the most. So I'll get off that. Transparency is interesting. I've been involved with it for a couple years. I ran some bills last session dealing with healthcare transparency. I sit on the interim committee, subcommittee now that Chairman Cafaro has put together and Chair Kelker heads on healthcare transparency. And I guess my comments, because I'm probably running over time, would be, we keep going. I think we have to have a discussion as to what is transparency. I've got a pretty firm idea in my mind as to what I think transparency is. And I think at the end of the day, last session, the bill that I carried was pared down far enough where, to me, it was a pretty basic definition and it was vetoed. So to me, one of the things as a legislature, if we're going to run this thing again, what is transparency? What does the executive think is transparency? What do you folks think that means? Because that's ultimately, maybe I'm wrong. And I don't want to spend a lot of time and energy and taxpayer money going down a road that's going to end up with the same as I had last time, which obviously doesn't work. We need to figure out what it is. In my simple mind, transparency has three components. And I'm really generalizing here, but I can get in more detail if you like. You have the provider. You need transparency at the provider. We already have some protections in law. We tried to do a few other things to tweak them. If a patient is going to choose a provider, they need to know what that provider believes it's going to cost. They need to know whether those services are going to be inpatient or outpatient or some combination of both. They need to know if they drive 90 miles, 100 miles away, that they have another option that maybe is affordable to them. Because it does no one any good when a patient goes to a hospital and can't pay the bill, which then turns into charity or uncompensated care, when they had options where they could go somewhere where they could pay the bill. So I think the providers do have a part of it. The insurers have a part of it. They negotiate with a lot of providers. If you have health insurance and that negotiation's done, shouldn't you have the right to look and find out what your options are, who your insurer has negotiated with and what the prices are, and make a decision as to where you should go. And you should maybe even have some incentive for you to make a good decision. If a health center maybe has low volume on a certain procedure and it costs $500,000 there, and they can drive across the state and get to another health center that does a little bit more volume on that specific area, and it's $200,000, that's $300,000 the system saves. And so I think that there should be something in there for people that make those decisions. And then the last party is the consumer themselves. Make good decisions, because there's still a way too much out there in the consumer world where, you're somewhat frugal as long as you got a deductible. But when the deductible's gone, you go, I can just do whatever I need, it's free. Well, it's not free. And every cent that you're spending at that point is weighing down the system. And if you can make some different choices, use different providers, explore other options, whatever we end up doing, and you save this system money, then this is going to be part of the reduction of the cost of health care. So I think those three parties have to be involved, the provider, the insurer, the consumer, and that's what we're, at least in my mind, that's what we're trying to do. Thank you.
Thank you, Senator Buttrey. Senator Cafaro.
So we're just supposed to talk about whatever we want to talk about?
Related to healthcare.
Related to healthcare, okay. Well, thank you for inviting me, first off, and thank you everybody for being here today. I'll talk about the budget. So in the end, Department of Health and Human Services serves, as probably you all know, people that have mental illness, developmental disabilities, senior citizens, Alzheimer's, dementia, veterans, children, people who are low income. They serve the people that I'm most committed to, and they took a huge cut in the end. And it starts out, as Senator Buttrey said, with the governor had a list of cuts that cut the budget by 4.7%, or $110 million all funds. And that list was scary enough, but the positive thing about the list was, number one, he had to do it. He had to, by law, he had to come up with a list of services to cut. But number two, the good thing about the governor's list is that if revenues come in between better than expected, then the governor has the opportunity to restore some of the cuts. And that's an important piece of information. Number two, the positive thing about the governor's list of cuts, and he actually implementing them as he did, is that that new lower level does not go into the base for the next biennium, and that's an important point. So what happened was I'm on the budget committee, and during the session, the Republicans decided to have a mini House Bill 2 budget bill and actually put the cuts into statute, which creates two problems as I see it. Number one, if revenues come in better than expected, the governor no longer has the opportunity to restore those cuts. That's really important. Number two, the other problem with the House Bill 2 is it lowers the base. So when we come back to the session in 2019, our budget will be lower than it was in 2017. Those are two really important points. So in other words, it instituted the cuts and took away the flexibility from the governor to respond to what could be an improving economy, to implement services, to restore services to people who most need them. I didn't vote for House Bill 2, as you can imagine. I did not understand why that was needed. And when I'm not a senator, I work as a grassroots organizer on behalf of the ARC Montana, working with people who have developmental disabilities and their families. And we organize town halls across the state. And what we heard from legislators was, this isn't our list. We would have done it differently. This is the governor's list. And I'm sorry this is it may sound partisan, but that's what we heard, that's what our families heard. And so in thinking about the special session, we were very hopeful that people from both sides of the aisle would come to the session, roll up their sleeves, and surgically go through the budget and find places to cut that did not hurt people who need services, or at least lessen the impact. But instead of that, we went in the opposite direction, and those cuts were instituted with House Bill 2. And voted on party line, Democrats against, Republicans for. So then I'll talk about some of the cuts. I think it's important to HealthCare because there will be a cost shift. People will, I'm sorry to be so down, but it's the truth. The cuts that are implemented or will be implemented are mainly to community services. And when you cut services in the community, everybody knows what happens. People show up in higher cost care, ERs will see more visits, and potentially the corrections department. So it was really important not to pass House Bill 2 and institute these cuts. So I'll talk about mental health. Case management was cut for children and adults, services in the home for children, the community crisis response grants were cut. That's a really important bipartisan effort that started back in, I think, 2007. Psychiatry, outpatient therapy. Eventually, I don't know where the people are going to bubble up, but they'll bubble up somewhere. DD, kind of the same deal, but not as severe as mental health. Senior and long-term care, home and community-based services were cut, durable medical equipment, incontinence supplies, personal care attendants, that type of thing. And special sessions are really hard because you don't really have an opportunity to develop policy and have good in-depth conversations with your colleagues about the impacts of the decisions you're making. And like I said, I'm on the budget committee, so we got there on Monday, and then yesterday and the day before, we were there from 7 until 1:30. So it's really hard to make the best decisions and to work as bipartisan as we usually do. I watched a little bit of the House, and I'm a senator. I work all the time with Senator Buttry. We usually do better work than we did at the special session, and I'll tell you right now, I'll take responsibility. I'm sorry that we didn't do better.
Thank you, Senator Cafaro. And, I might add on the tail end of that, somebody in an op-ed, and I forget who it was, this last week said, special sessions are really a terrible place to try to get things done because everybody's in such a mad rush. You have such limited time. And we have 150 people who are paid very little by taxpayers, who have day jobs, who 20 out of 24 months are doing those day jobs, and they take a few months every couple of years and a week or two for the occasional special session to come into Helena. And being here in Helena, you get to see it a little bit more up close and personal, and I just think it's I'd like us to do something unusual. Let's give these folks a round of applause for their service. It really is, it's heartening to see a citizen legislature come in and do the work you guys did the last few days. Yes.
Do it for the money.
Yeah, that's it.
The glory. Representative Kelker.
Well, I'm not going to spend a lot of time on the special session except to say that if there is good news, it is that we did mitigate some of the cuts that were intended to be implemented if we couldn't figure out a solution. So that's, in my mind, is a positive. I think what the whole process revealed to us is that we are very dependent on community-based services to provide for folks who need health care and mental health treatment and so on. That system was developed over 40 years ago. I was there at the dawning, and it needs some work. These are different times, and certainly the healthcare situation has changed dramatically in those 40 years. And so I think we're going to have to roll up our sleeves and do some very deep thinking about how do we properly support that community-based set of services. They've provided wonderful services over a lot of time, and they're better quality services in general for the people who receive them. But we haven't figured out how to pay for them. So I'm very prepared to take a look at those things, but absolutely you can't make decisions about programs in these 2.5-day sessions up late at night. That's not our best thinking. So I would ask you, the people in this room and your colleagues, to help us think about how can we fund community-based services, because they are a good idea. And we have to make some reforms 40 years later to make it work more effectively. So I would like to talk about the Healthcare Pricing Transparency Subcommittee. Our chair of the Child and Family Health and Human Services Committee was very wise in saying this is a very big topic and it can't be discussed in the whole committee adequately, so she allowed us to create a subcommittee, and it's a rare opportunity. Usually during the interim, committees are entirely, their memberships are entirely legislators, but in this case we have 4 legislators out of 15 members. And already I can see there's some benefits to that. There are 2 Republicans and 2 Democrats, and we will learn far more about healthcare and how things work than we could in any other way, I think, during this process. The other 11 people represent all aspects of healthcare. If you're in the legislature, it's not just medical issues that are described by healthcare, but it's the dentists and all the auxiliary services like OT and PT and so on that are included in our list. We have a consumer expert on the committee. We have a CEO of a critical care hospital. We have a CEO of a major hospital. We have Bob Olson from the Hospital Association. I think I saw him in the room, who knows the numbers better than anybody I know in terms of medical costs. We have representative from insurance, and we're very fortunate that we have someone involved who has been kind of the founder of self-insurance in Montana, Kevin Larson, who is the CEO of EBMS in Billings. We have a a physician who is a primary care physician who has been very active in the leadership among physicians. And I asked the Chamber of Commerce to nominate people for our committee, and they wisely chose a CFO from the Billings Clinic. And I promised I wouldn't choose anyone from the Billings Clinic because my husband was a doctor there, and I'm, very wedded to that particular institution, but the chamber chose that person. They also chose an employer, which has proved to be a tremendously helpful component to the committee. So we have representatives also from state government. We have someone from the state fund, the medical benefits from at the state, and a member from the auditor's office. So it's a pretty well-rounded group, and so far the discussions have been lively. I would add to what Senator Buttrey said about transparency. You have to have that employer component because in this country anyway, health insurance is offered by employers, and we are unique in the world in doing health insurance that way. So we have to have that component. And the woman on the committee is an owner of a small business out of Glasgow. So she has that rural perspective, plus she's an employer. The bill that created this subcommittee is a little different from what Senator Buttrey was talking about a few minutes ago. We did have 5 bills on healthcare transparency in the last legislative session, and none of those passed. The only one that, all the way through the process, the only one that did was a study bill, and that's what's created the subcommittee. And it was the highest rated of all the possible study committees that would occur during the interim. And I think that's because every legislator recognizes that healthcare is, one, an economic engine in our state, and also a difficult thing for consumers in terms of their cost and their understanding of how healthcare is delivered. So there's a broader purpose for this subcommittee. We are supposed to look at the factors that influence pricing, at what other states are doing to bring down costs and properly educate or helpfully educate consumers. And we are to figure out ways to inform consumers so that they can make better choices. And we are to look at the existing tools for helping consumers that already exist in Montana, and add to the look, not just the price, but the quality of care and the outcomes. So if you're a consumer, you know what the price is and how that's determined and how that affects your cost, but also how does that price coincide with the service that you're looking for. In the United States, there have been several studies that show consumers choose the highest priced, highest cost service because they think it will be better. And that's, of course, not always the case. And lastly, we are to bring together the whole topic of costs and quality and decide how we are going to deliver that information effectively so it can be used by consumers. Those are items right out of the bill. We've had basically 2 meetings. One of them was an organizational meeting. And just to wrap this up, I have a research assistant to help me in working on this subcommittee, and he is an economist. He knows a lot about the economics of healthcare, and he is totally neutral, sort of anti-political, and he is helping me to choose the best quality studies and evidence-based information. And Connie Pruitt is in the audience. She can tell you, we send out homework in advance, And it's meant to be a real study of what's going on and what is best practice from all over the United States and sometimes all over the world. So it is definitely a nonpartisan discussion. It's all about evidence-based. I'm really excited about what might come out of this particular subcommittee. And I want to say that the most important thing to me so far is the way that people have responded to the topic. I get calls, emails all the time. It's overwhelming. People saying, I want to help. I'm in the healthcare field. I'm a consumer. I'm an employer. I love what you're doing. How can I help? How can we coordinate? How can we do this better? It's just been unbelievable to me. So I feel very responsible for meeting that demand, because people do want to get together and do a good job. So stay tuned. We'll have some good results, I think.
Thank you, Representative Kelker. That's an important issue for all of us. I know I have a very strong opinion about this transparency issue. I've developed a white paper, and if you'd like a copy, please fill out the non-disclosure agreement on your table. That was a joke. I'm sorry. But it is fascinating. I look forward to hearing what comes out of the committee. And last, and certainly not least, we have with us I'm sorry, I always get the representative senator thing. I just have to kind of look down. So we have Representative Dennis Lins from the Billings area as well, and would love to hear your thoughts, Representative.
Thank you, Richard. I'm always keeping my eye across the room at everybody's, since I'm in the fourth place. Is everybody paying attention? I want you to know I do have a canary in the room, in the mine. It's my wife here in the front row. If she starts nodding off, I'll cut it off quickly. I have an interesting perspective, a little bit different, and it also melds in some of what they've touched on. I've been 24 years retired as a fire captain from the city of Billings. We've been farming our family farm for 30 years of that. And as I retired, I also kept my feet in the pool of maintaining my EMT certification and stuff, which has put me in a position of at the trainings of interacting with volunteers and how healthcare impacts the rural community, particularly Medicaid reimbursement rates for ambulances and difficulty of finding volunteers for those ambulances and how they're modifying providing the services to their areas has been an interesting concept I've had through this. But most of how I operate as a conservative Republican, a lot of times the health care and the health and human services is not as appealing. I have intentionally put myself in that arena. I told Senator Cafaro I originally asked to be on Native American, I can't remember the name of the interim committee, because I find the interaction between the legislature and the Native American community very fascinating. But the last day I walked in and said, I need to be on this committee. I have the blessing of having her as a chair of the committee, her wealth of information, and I'll touch on that. Her, Senator Buttrey, and Representative Kelker, I actively seek to put myself in that position. I feel like I'm behind the curve a lot of times, because maybe I don't understand things as well as I should, but I want to understand them. I want to understand how the budget impacts the poor, the elderly, the disadvantaged in this state, and so often between the possible sterility of the budget, just the dollars and cents that are exchanged and how that impacts is difficult, and finding my voice to articulate that. No, wait, this is important, to at least push the dial a different direction. That is kind of where I sit. These guys touched on so much: the budget, the transparency, and the overall the Medicaid in stuff that we're working on. So I won't expend a lot of energy on those lines, but it's so important. We're at a point in our state where these healthcare dynamics are so much as a tipping point, and which direction are they going to tip? And to be able to articulate that to not only our caucus but to the people that I interact with, that's where I sit. So bend my ear. I'll be glad to listen. I will leave it at that. You're all still bright-eyed. Honey, you're awake? Yeah, she is. We're safe. We're safe. All right. Thank you.
Thank you, Representative Lenz. Well, good. We have some time for some Q&A, and I would extend that to encourage the participants to feel free as these questions are asked to ask questions of one another and to respond. If a question is directed to one person, feel free, if you're not that person, that after the first person answers to give your opinion as well. So it'll be a bit of a free-for-all. And who has the microphone? Microphone is back here on my left. So who will go first? Oh, there we go.
We go testing. Oh, excellent. All right. Well, thank you all for being here. And again, where we are about 10 hours since the session ended, so I'm sure everybody had plenty of sleep. Regardless, it really means a lot for you all to be here and take the time today. My question, I guess, if all you could briefly touch on this, or as many of you as you would like to. I think we heard a little bit from some other panelists as well about the healthcare workforce and the expected retirements coming up. Wanted to see if each of you could touch a little bit on how the legislature is currently playing a role in how we're shoring up those very important healthcare workers in so many spheres of this industry, and what you think the legislature could be doing more or less of in that field. So we could start with whoever wants to kind of speak up on that one first. Thanks.
Please, Representative Kelker.
I think one of the most exciting things that has come through the legislature, and the legislature's been involved in this way for some time, are the residencies that have been supported. The Billings Clinic has an internal medicine residency now established and going well. I actually have a new physician for myself, and it's one of the people that went through the residency program. Very nice young woman. I think from the speakers who were in the earlier panel that we all learned it's important that you try to get physicians to love coming to Montana and working perhaps as the primary care physicians, and that's why this internal residency is so valuable, because it's creating new primary care physicians, and they have a chance to do their residency here, and that all the research shows where people do their residency is likely to influence their staying in that particular place. So that's good for Montana. There was a proposal for the psychiatric residency. Again, that's an area in the medical field that we desperately need in Montana, and through some manipulation, it was successful through the legislature. It's not that it's not a great idea, it just was a very tough year for anything that was a new program to be funded. But that's a way I think that the legislature can be very influential in getting quality physicians to learn in Montana, get their residencies here, and then stick around. Very important.
Thank you. Anyone else for that one? Senator Buttrey?
Sure. I think Representative Kelker was right on target, and I think there are some things that we've done. Some of the things we've done aren't necessarily loved by all the folks in this room. We did implement the updated Nurses Compact, which is allowing us to continue to be part of a compact where we can get nursing staff into the state as we need it, and I won't go too far into that, but we've had a pretty good program for training our docs, the WWAMI program. We did make some changes in this past legislative session to encourage those folks utilizing that program to come back to Montana. WWAMI is a taxpayer-subsidized program. Montana taxpayers pay for these students to go and get their medical education, and if they don't come back to the state of Montana, it didn't really seem fair that we were continuing to burden that full amount of money to someone that wasn't coming home. I think, and since Mary was allowed to get a little angry, we missed an opportunity. We missed an opportunity this last year for a medical school in Montana. It was interesting because we were working through the process. We had someone that wanted to bring a multi-state medical school into this state to take Montana students and our surrounding state students and create residencies and clerkships, because we recognize that we have an aging workforce in the healthcare, and this was going to be a huge help. And we got political on it. We stepped on toes. We have had very powerful programs that work in this state, and we offended the wrong people, and we lost that opportunity, and that was a real bad miss. Would have been a lot of money in the state, a lot of construction, a lot of ancillary business, and a lot of money for the university system. We missed out. Good news. If you've seen online ICOM, which is what it's called now, Idaho College of Osteopathic Medicine, they went to a little community outside of Boise. This thing is rocking and rolling. It's going up fast. It's almost completely structurally built. And now they're having to build condos and apartments next to them because of all the folks coming into it. They are establishing residencies and clerkships in Montana, just as they always said they would in other states. And the really cool thing is Montana kids are going to get to go there at an in-state tuition rate without taxpayer subsidy. That's just another option. Now we're going to have the option of 2 medical schools to bring folks into this state, and I think that's going to be a real big positive.
Representative Lenz, and then Senator Cavero.
One of the keys that came up the last legislative session was expanding the scope of practice for EMTs and medics, paramedics and such, to maybe fill in this gap a little bit more. 2 bills that came forward were not well written to define that scope of practice. And as to whether it can even happen, that I don't know. But I think it's something we need to look seriously at as to whether we can make that happen, because we already have partially trained people, particularly the paramedics that have even a higher level. That could be a component of that. Something I'm looking at. Senator Sands was pursuing that very strongly, and she is on our interim committee. So I do continue to look at that.
Thank you, Senator Cavero.
So what if I told you that, what if I told you that we had a policy opportunity, and I hope we have another one, that would save the cost of HealthCare, prevent kids from smoking, and help to shore up workforce shortages for direct care workers that work in nursing homes that provide care for people who have physical disabilities, DD, mental health, senior citizens in their homes. What if I told you we had a policy like that? Wouldn't you love that? I do. I mean, not all taxes are created equal, and the tobacco tax, I was asked to sponsor it, and at first I said, no way. I mean, I didn't want anything to do with it. I'm tired of taxing smokers, is what I said. But then they brought me the research. I'm like, oh my God, I love this. Because 90% of long-term smokers report having started as kids. 90% of long-term smokers report having started as kids. And in Montana, what we know, and across the country, but particular in Montana, was when we raised the tobacco tax the last time, 50 cents in 2003, and then on the ballot initiative another $1, that I think it was the reduction in children starting was reduced by 50%. And there were other strategies too, but by 50%. So get it? The idea is if kids don't start in the first place, then we reduce smokers overall. And then the other thing that's so important to know is that $80 million in Medicaid spending per year goes to tobacco-related disease, $440 million in all healthcare funds, $440 million a year for tobacco-related disease in Montana alone. So you can bring down the cost of healthcare, have a tool for kids not starting in the first place, and provide a revenue source to pay for direct care workers, give them a raise, $4 an hour over 4 years, sustainable model. That's something that the legislature can do for workforce shortages. We have huge workforce shortages. Even if we had the money, people wait on waiting lists for a long time before they can have somebody come and help them take their bath in the morning to get up. So it's really, I just love the tobacco tax, this particular bill. Like I said, not all taxes are created equal. It's a tax you never have to pay. Just don't smoke. It's a tax you never have to pay. It also taxed for the first time e-cigarettes. They're not taxed at all, and they are categorized as a tobacco product by the federal government. And then it equalized all other tobacco products with cigarettes, because cigarettes are currently taxed at a higher rate than other tobacco products. And so there you go. That's something that the legislature can do to help with workforce shortages in the healthcare industry.
Thank you. Yeah. Other questions in the back?
Hi there. Thank you for being here. I know it was a late night, and we really appreciate your work. I want to get back onto transparency. I think some of you know that I work for the Primary Care Association, and I wasn't super supportive of some of the transparency bills that happened in 2017 because I'm worried that we might be asking the wrong question, that we're asking the question of output. We're asking what is the cost of a service from the provider to the consumer, which is the end of the line. That's the output. And I'm wondering what the panel or what the study group might be looking at in terms of the inputs, the costs going into the system that are driving the output costs. And I think, Commissioner Rosendale, kind of teed that up with the cost of prescriptions.
Thank you. Who'd like to take that? Yes, Representative Kelker.
I'd love to take that question. And it's a very good question. That's why this particular subcommittee study is broader, so that we can look at the whole picture. And the very first panel that we had was on costs to providers. What does it cost for you to provide the services that you're providing? And it was so interesting. One of the speakers on the panel was from a critical care hospital, and he told us about his budget and so on. And he said that he paid the highest cost in his budget was for the electronic medical record, which he loves, which he's glad he has. But he has a $400,000 cost annually to keep it up. And for a small critical care hospital, that's a huge hit in the budget. That sort of set us all back. We are not studying, in the subcommittee, we are not studying prescription medications, but that topic did come up. There was a dentist on the panel who talked about the cost for him of the kinds of medications that he uses in his general dental practice. So we are getting the whole economic screen. We're looking at cost to the provider. We were supposed to be meeting today to have this discussion, but we're looking at pricing and how that occurs in terms of all the payers involved and why consumers pay different prices for the same service and how that all plays out. And we are looking at clinical changes, things that are done or can be done medically and in other kinds of healthcare practices that reduce cost in providing the service. Scheduling your operation rooms in a different way so they're more efficient, things like that end up saving a bunch of money. And then we'll be looking at decisions that consumers make that relate to cost and price, and we'll come up in the end with as many recommendations as we can to things that we can really address that altogether have an effect on transparency and on pricing. Does that answer your question? Gives you hope. Gives me. Oh, it is. It's very complicated. It's not just simply posting on a bulletin board how much it costs to have your knee done. Most of healthcare is not a procedure that has a beginning and an end. Most of healthcare deals with chronic illnesses or disabilities that are a lifelong sort of cost to the individual and to the system. And really, transparency in that pricing is just sort of not heard of. So we got a lot of work to do.
Representative Lenz?
Yeah, your comment about whether we're asking the right questions or not, I think it's a benefit to you that we're asking questions. Because a lot of times we don't understand the mechanics of that. And so we come down, let's go this direction. It's as simple as I go to the mechanic and I'm going to get something fixed and they say, oh, you have to get an oil change too. Okay, well, I understand that. It is much more complicated than that. And so as we ask the questions, we are processing what that looks like and are glad to do that. And that, from my position, that's what I have to do. I pick a direction we're going to go, and it may not be the exact direction, but please be patient with myself and the legislature because we realize it is important.
Thank you. We have a few minutes left for one or two more questions. Yes, over here.
Real easy question. Is there a way for us to listen into the committee?
Is there a way to listen into the committee?
Yes. You can go to the website for the state legislature, on that website, you can go to interim committees. That's one of the choices. You can pick which interim committee you want to hear, and you can listen to the audio tapes, and there are sometimes videos as well of the meetings that have already taken place. During the actual live meeting, you can get into streaming and actually feel like you're present and part of the committee, and just listen to the whole thing if you want to. So, very easy. I'm sorry? The next meeting is the 17th, 18th, and 19th of January. Our meeting for the subcommittee will be the 17th.
This will be an easy one. Representative Kelker mentioned the cost of replacing a knee, and I think that example and the MRI example are ones that are often tossed about as, this is where we need transparency, and I absolutely agree. I supported, I think, almost every single transparency bill in one way or another, Senator Ruttry, during the session. But what about the rest of it? And how deep can we go really on a state level, knowing that over 80 cents for every dollar goes to the management of chronic care, things like asthma and cancer and high blood pressure and diabetes management, rather than the knee replacement and the MRIs. Where do you go with that isn't quite so readily available with a transparency widget?
I'll just briefly comment. I think Chair Kelker is going to have more to say, but obviously, some of the work we've done in past sessions at legislature has been to make sure as many people as possible had access to preventative care. Until people have the ability and are able to get seen by a doctor and to make sure that we catch them before they become diabetic, we can help with weight issues, we can help with drug addiction, we can do those things. Those are important. Otherwise, in a state like Montana that has a very aged population, you're going to have a lot of chronic people and you're going to have a lot of expense you just can't do anything about. So I think that's something that's important. And I agree with the conversations we've had about transparency. Not only is the output at the provider, what the cost is, but what can we do on the front end. I think I've more traditionally focused on the back end, because no matter what happens at the Fed level or state level to affect the cost of drugs, the appliances, the liability, all those things that happen, I still think at the end of the day, the consumer has the right to know what they're going to pay. They have the right and responsibility to consider options and make good choices. We've struggled with that because there is a lot of cost shifting that goes around. And if we know we like the knee example, and we like certain other ones, and we said, well, let's just pick 10 procedures and say, okay, let's find out what the pricing is around the state and make folks declare what the pricing is for those 10 procedures. Well, I mean, what'll happen is those 10 procedures will get very cheap. But there's going to be something outside the scope of what we're looking at through transparency that magically is going to rise. That's just the way the system works. So whatever we do is going to have to be comprehensive. But I do agree with you that if we don't handle the issue of health care before folks get chronic, how much difference are we going to make?
Representative Kelker?
I'm going to go a little bit further with this question. I think it's very important. The procedural sort of competition, whose knee is cheaper, I just want to add to that discussion, you need to know also what the outcomes are and how rehab takes place, and how many days does the person stay in the hospital or some kind of a healthcare facility. I mean, and those things are not usually readily available unless the consumer knows how to ask those kinds of questions. But in terms of chronic illness, let's just take that. It is the cost driver of cost in healthcare. And what is emerging, and I am certainly not a medical person. I just live with one, but I didn't go to medical school. But I do read the articles because I'm so interested. There are protocols being developed now and experiments being done that are very promising, that show, if, as Senator Buttrey said, if you have a person with, let's take diabetes as the condition, who is working with a primary care physician, and there is follow-up with that person on a regular schedule, maybe it's the nurse practitioner or someone other than the physician, but someone is contacting that person and finding out what their sugar levels are and, all of that stuff, that the outcome for that person is so much better. And if that also includes exercise and diet with the nutrition person and, all of those things, you get a better outcome. And when we know what those protocols ought to be in a general sense, then the physician has the ability to tailor it to a specific individual, because everybody's different. But you are using those steps that are proven in the general research world to be effective and cost effective in helping someone to manage their chronic illness. And really, it's kind of similar in, say, mental health issues, addiction issues. It's a chronic problem. There are protocols that seem to work better than others, and that's a way of saving costs to the consumer and to the system. So I would say that's emerging. It's implemented in some places in Montana already, and a lot more of that is going to come. And I think that's a very promising area that actually at our next meeting we are going to be looking at.
Thank you, Representative Kelker. Representative Lentz.
One of the things we mentioned, the cost drivers here, and I don't hear it often, though it does come up, is the palliative care aspect. The end of life, the bulk of those costs being at the end. I know as an EMT that a cardiac arrest from a trauma, the chance of surviving that, even if I do excellent CPR, is less than 1%. So there are also diseases and stuff in the hospital that we can kind of quantify what that looks like. And it's not talked about a lot, and that's very, very difficult. And I would love to continue down that road to have that discussion, to start asking those questions so we can and start moving that direction.
Thank you. And we're out of time for further questions, but I wanted to just mention to everyone here that if you found this panel to be helpful, I know I did, we have a lot more of this coming down the pike in less than 2 months. On January 10th and 11th, we have business days at the Capitol. I believe it's going to be here. Is it, Webb? In this, yeah, probably in this very room. And we'll have legislators on panels. We'll be able to talk about what's happening in Helena. And just wanted to kind of put that plug in while we all were kind of appreciating what these folks do for us at the session, and as well as what they did for us today. So let's thank our panel.